Hello, friends. Today we'll talk about the interpretation of culture reports and the concept of therapeutic index. So, culture reports are something we encounter in our daily ICU practice, yet they are often underutilized or even misinterpreted. Behind every SIR or MIC value lies critical information that can shape our antimicrobial strategy. So, today I'll walk you through how to systematically interpret culture reports and how to apply the concept of therapeutic index in guiding rational antibiotic choices. So allow me to share the slides, please. So as discussed, we'll be talking on the interpretation of culture report and the concept of therapeutic index. I am Dr. Bharat Jagiasi, Director of Critical Care Department, Kokilaben Hospital, Navi, Mumbai. So what will be discussed in this talk are about the time to positivity, what exactly it does means and what are the rationale behind it. Terminologies in culture report, various terminologies being used, including minimal inhibitory concentration, that is MIC, breakpoint, and also eventually the concept of therapeutic index. So when we talk of the time to positivity, this is related to the blood culture. So this refers to the time taken for the blood culture bottle to flag positive. That is from the moment the culture is being laid, gone for the incubation till it flags positive. It's called time to positivity. And of course, the more the number of bacteria, faster it will flag positive. So lower would be the time to positivity. So that means lower the time to positivity, higher is the bacterial load in the blood. And this is why this is also an indicator of a prognostic indicator as well. So if the time to positivity is less, that means the inoculum of bacteria is very high. So of course, more chances of the severe disease, more chances of septic shock, and eventually the more mortality will be seen. It can also help us in rule out the contamination, like a very long time to positivity, which is often over 24 hours, can suggest a contamination of the blood culture sample rather than a true infection. So if the culture bottle has taken more than 24 hours to flag positive, it suggests it's more of a contamination rather than a true infection. It also let us know about whether the infection is coming from the central line or the another lines as well. So there's something called a differential time to positivity. So supposedly blood culture has been taken from the central line as well as the peripheral line, and the central line flags positive 2 hours earlier than the peripheral line. That means this is a Klebsiella central line associated bloodstream infection. And consider removing the central line in those situations. And this is called a differential time to positivity. So if you look here, always see what is the time which was flagged positive. Here it's 11 a.m. Suppose this is the peripheral line. And in the central line, the same organism was flagged somewhere around the 8:30 or 9 a.m. So that means there was a differential time to positivity, and it has grown from the central line, and we need to remove it. Also, when you come across the culture reports, you always see there's something called as SIR and SDT as well sometimes. So what does S means is susceptible, that is antimicrobial is effective in standard therapeutic doses. Intermediate, clinically effective with increased dose or the frequency we have to see depending on the PKPD of the antibiotic and exactly what is the site of the infection. SDT is susceptible dose dependent. So when we go up on the dose, it will be acting, the bacteria will be sensitive, otherwise it will be resistant. And the resistant is ineffective in standard or increased therapeutic dose. That is antimicrobial with resistant can be considered for treatment when resistant to all drugs only. Otherwise, we should avoid using such antibiotics. And there's something called as 90-60 rules. That means what? Susceptible infection respond to appropriate therapy approximately 90% of the time. So supposedly is come S, that is sensitive, susceptible. There are 90% chances it will act against the flag positive bacteria. And still there are 10% chances it will not act. Whereas resistant infection responds only in 60% of the time. So that means when it's resistant, it doesn't mean it will not act at all. Still there are 60% chances this might act. And this is the reason why when there's a PDR, we can consider using antimicrobial with resistance with flagged as R. Of course, looking at the PKPD, eventually we have to maybe in those situations we have to combine the therapy. We have to use a dual antibiotic or different doses, but that is a different topic altogether. Here we are just trying to understand what these terminologies mean and how we can interpret and utilize in the clinical situation. So same, now we have to move towards the concept of therapeutic index. To understand the concept of therapeutic index, we need to know what does MIC mean. That is a minimal inhibitory concentration means. It's the lowest concentration of drug which prevents visible growth of bacteria. So the various concentration of the drugs has been used, and the minimal lowest concentration where the bacterial growth was inhibited is termed as MIC. There's something called as break point, which is a chosen concentration of antibiotic, which defines whether antibiotic is susceptible, intermediate, or resistant. So there are certain values given by the various organizations like CLSI, UCAS. So as per those values, the minimal inhibitory concentration where the bacterial growth was inhibited, it defines whether it is S, I, or R, that is susceptible, intermediate, or resistant. And when the test isolate is susceptible to more than one antimicrobial of similar pattern, it's often difficult choice by the clinician to choose appropriate antimicrobial or directed therapy. And most of the time, what we eventually do is we look into the lowest MIC and choose it, which is not the right way of doing it, and it's also not the right thing. Why? I'll tell you this. So we have to choose the narrow spectrum with the highest therapeutic index. And how do we come across the therapeutic index? So therapeutic index is B by A, that is, it is the ratio of susceptibility breakpoint in MIC to the MIC of the isolate. Now, if you see over here, so again, this would vary in the context of the type of organism, site of infection, the creatinine values of the patient organs affected. So that's a different talk altogether. Here, this I'm using this just to make you understand how the concept of therapeutic index works in different scenarios. So usually, if you see what we look into is we look into the lowest MIC. So if you look the sensitive organism, the lowest MIC here is somewhere around 4. This is what we look into, or also the 2. But the therapeutic index is what we have to look into. So here is 4, and again here is 4. So we have to choose an antibiotic with a narrow spectrum, higher therapeutic index. Though it seems like the MIC of the colistin is 2 and of the gentamicin is 4, so clinician might end up choosing colistin over gentamicin, but no, both have the same therapeutic index, and BKPD fits well depending on the site and type of infection. Gentamicin would be the type of antibiotic because it has a narrow therapeutic uh, range, and also it has a higher therapeutic index. To go in with one more example, if you look into the susceptibility breakpoint, that is MIC, which is given by the various societies. Now, if you look here as per the sensitivity pattern, there's the lowest MIC what we're looking here is 2 and of course the 1. So we might end up choosing somewhere around 2 and 1. But if you look into this, the highest therapeutic index is 8, which is by the amikacin. So this is the right antibiotic when it fits into the other context as well. That is the site of infection, type of infection, the organism involved. One more example, here the highest therapeutic index is 8, which is true with the amikacin. But if you look into the MIC, the lowest is with the ceftriaxone, but here the choice of antibiotic would be with a higher therapeutic index if fit into the context, that is the amikacin. If patients is if it's a nephro safe in the current situation, we can continue using amikacin with a higher therapeutic index. So this is why it's important to know the therapeutic index, because when you come across this kind of a chart where there are multiple antibiotics sensitive, so we end up using the lowest MIC, which is not the right point, because the MIC varies with the different drug, but the right way of using is the ratio of the susceptibility breakpoint to the MIC of the isolate. Now, when do we repeat cultures? So, repeat cultures are recommended in case of the Staph aureus bacteremia. So, this is recommended to assess for persistent bacteremia and guide ongoing treatment. Of course, same is true with the infective endocarditis to monitor the effectiveness of the antibiotic therapy with a negative follow-up culture confirming treatment success. In candidemia, we all know this. It recommends daily or every other day blood culture during treatment of candidemia, and the duration of treatment continues after the last culture was negative. Uncertain significance of initial culture, so there we come across a situation maybe necessary the positive culture has uncertain significance, and such we consider maybe it's a contamination or the catheter related infection without a clear source, so we tend to repeat culture in those scenarios as well. Again, in the febrile neutropenia, it's a recommend obtaining 2 sets of blood culture on the first 3 days of persistent febrile neutropenia to guide management. So this was all about the culture report, how do we interpret, and also about the concept of therapeutic index. So it's far more important to know what person the disease has than what disease the person has.